Hi, my name is Elena, and today we're going to talk about prone positioning and ARDs protocol and how just our oxygen exchange and blood flow affects all our systems and how prone positioning helps a lot of our ARDs patients to be able to oxygenate better and have a better outcome. Okay, this is prone positioning continued. Just kind of talking about effectiveness of prone positioning, skin breakdown prevention, and then considerations. The effectiveness for prone positioning, oxygenation is the main thing, monitored via arterial blood gases, PaO2 and FiO2 ratio, and then continuous pulse oximetry. Respiratory mechanics, assessment of lung compliance, and reduction in driving pressures on the ventilator. It's like getting your NIF and your plateau, your static, and your dynamic compliance. Clinical outcomes, reduce mortality, lower duration of mechanical ventilation, and reduce need for escalation of care. The physical assessment, regular assessments of skin integrity, face, and pressure points for complications such as pressure sores or facial edema. Especially on the facial edema, just because if there's a lot of swelling and fluid or like secretions coming out of the patient's face, that can kind of start interfering with the taping. Because like I spoke earlier in a prior slide, some facilities do have specialized ET tube holders for prone positionings. Not all facilities have access to those. So if they don't, they have to tape. And with all the secretions and the saliva, that obviously breaks down on the tape and the stickiness, which can, eventually lead to an accidental extubation on the patient. Chest imaging, frequent images, CT, X-ray taken to assess lung aeration and compared to supine image. Just like those CT images, it showed like when a patient was not prone, their lungs weren't expanding as well, so they weren't oxygenating and ventilating and perfusing appropriately. That one lung was a baby lung, and then once the patient was prone, the opposing image showed how much more oxygen and how much larger the lungs got. Skin breakdown prevention. They have a lot of silicone face barriers. For intubated patients, to use cushions and pillows to help alleviate pressures on the ET tube, the IG, use of specialized ET holders. Like I spoke earlier, specifically for prone positioning, some facilities have those, not all. And then considerations, upper extremities, the swimmer's pose, one arm up at a 90-degree arm should be alternated every 2 to 4 hours. Head and neck neutral alignment or slight turn alternated with the rotation. So depending on the motion of what arm is up, the face will be facing away from that arm. And then when it's alternated again to the opposing side, then that face will be turned just to prevent specific face sores with the patient's face being on the pillow for X amount of time. Most of these prone patients are in the prone position for anywhere between, I want to say 14 to 16 hours at a time. So all like constant monitoring is very, very beneficial and crucial for these patients. Chest and abdomen pillows under chest and pelvis. Abdomen is free and not compressed. So the abdomen, they can't apply that much pressure because then that'll push up into the lungs and then the lungs can't expand. Lower extremities, neutral hips, slight knee flexion, and ankle supported.
All right, come on.
So this is a sample video.
Roll all the way.
It's not letting me play, but this is a sample video of me proning my daughter and my son helping me. Sorry for the giggling and all that, but they had fun and they were very helpful. So basically for a proning, patient is on a flat sheet under the patient, and then there's a flat sheet on top. There is 2 nursing staff or just medical staff that will come in and roll it really, really tight all the way to the patient's arms, kind of tuck it under a little bit. So then depending on what way they're going and like what they talked about, what position they're going to move, the person, like with me, I pulled the sheets so that the patient could move towards my side. Once I pulled her to her side, my son was able to hold her for me while I reached under her and got the other rolled
Over
up
here. Hold
sheets
the
and
patient.
pulled it under her so then she was
Hold the patient. Hold the patient.
put on her belly and prone. And then after that, RT is at the head. So they secure everything, they check everything, ET tube placement.
Not yet. Be still.
Nothing's been kicked, nothing's been disconnected, ventilator
Patient in
settings,
neutral.
parameters, alarms, all that is good. And then RT kind of documents their
All right, come
portion
on.
of it, and then nursing
So be
staff
still.
takes care of
Be
the
still.
rest. As far as like
You
patient care, wipe
roll
down,
all the
all
way.
that.
Tight.
This is my works cited. And then my reflection for this presentation, it has given me a deeper dive in ARDs protocol and prone positioning. My first time at clinicals when I did see a patient being prone, um, it was very, it took me kind of back a little bit just because I wasn't 100% like I didn't really know the concept of why and how it would affect their oxygenation. I just knew that they were being prone. So later on, after we helped and assisted on that proning, I kind of asked the RT, like, what was the deep dive on why the patient was being prone, and the patient, had severe ARDs. They were just trying to get a better oxygenation, ventilation, and perfusion situation going on for them. And then she just kind of deep dived and said, that during COVID, a lot of patients were getting prone because that seemed to help those patients and their outcomes kind of came out a lot better. Um, so I just feel like seeing that in clinical and then kind of putting two and two together and seeing how it does help them, how it does kind of balance out their pH a little bit and they're able to compensate. Um, I did like how the dynamic of the team, how like they got together, all the nursing staff, and like everybody had their assigned job, everybody knew what they were doing. As a student, I was put at the head of the bed and I was in charge of the ET tube, and that was a little scary and daunting. I was like, please don't self extubate because that would be beyond scary. Um, but I was able to see, firsthand how important an RT's role is to maintain that airway. Just because anything can go wrong, and in those situations, an extubation, like a self extubation or an accidental extubation, would be so detrimental to a patient like that because they already are not oxygenating well. And if something was to go wrong and they were either already prone or halfway prone, they have to get that patient back on their back, either, start CPR or like start, rescuing this patient and trying to get them back intubated to, not lose them and not become fatal. Um, I did like the teamwork of it all and how everybody had their job, how everybody was able to do everything, and just how amazing just a simple proning position, and how crucial it was for patients with ARDS or, um, patients that are having a lot of ventilation and perfusion issues, and how great it helps them and how much rest it gives their lungs enough to recuperate to, so that maybe they can come out of it and and live a semi-normal life and get back to their normal things with their loved ones. So this is my presentation on proning positioning and ARDS management and protocols. It has taught me a lot. I did do a lot more deep dives, so I was able to understand a little bit more, and then just kind of see how blood flow and everything kind of comes together. Obviously, without blood flow, we wouldn't have perfusion and oxygenation and ventilation. So it's kind of coming full circle now, and that's an amazing thing to be at this point and understand why each disease does what it does and what we can do to manage or cure or just kind of keep it at bay and help patients, live the best life that they can. Thank you, and I hope you enjoyed my presentation.